right. Well, good morning, everyone. My name is Martin Garcia. I am the moderator of this AEP session. We welcome to this month's presentation where we will be meeting MD, Assistant Clinical Professor from Division of Hematology and Oncology from the Department of Internal Medicine, UCSF from Fresno. We are enthusiastic about our presenter today, but before we get started, let's do a short exercise to bring us all together as one in this place and time, also known as the moment to arrive. So now, if we can all get into our comfortable positions, you're sitting, get into a very comfortable position. So we're going to take our first deep breath. So let us take our first deep breath in. And as you feel your lungs expanding, exhale and allow yourself to relax in your seat. Taking your second breath. Exhale. Your third breath in and exhale. On these next 3 steps, I want you to think about something great that you have accomplished or will accomplish this weekend. Take your first breath in. Exhale. Inhale. And exhale. Your third breath, I want you to inhale and feel yourself within your surroundings, clear your mind. Exhale. Now these final 3 breaths, I just want you to breathe out. Inhale. Exhale. Take a second breath in and exhale. Now for your final breath. Inhale and exhale. Awesome. Well, now you can open your eyes if you haven't closed. Now I want to thank everyone for doing this exercise moment to arrive. Now that we are all together at this point in time, I do want to address a few rules of the house. So we will be muting all conference lines to eliminate any background noise throughout the session as this is being recorded. Any questions that you may have can wait till the end of the presentation, or you can also, what you can also do is send them in the DMs and we can ask the questions for you. We will have a recording of this presentation as well, having the PowerPoint, which will be available to you. However, we do ask that you fill out this AEP evaluation, your feedback on the effectiveness of this presentation before you can receive them. So please understand that these surveys are vital for us to better understand how to make our presentations more effective towards your education and the quality of your life. So today we welcome Dr. Bukari, and I would love to introduce transition this to Dr. Bukari.
Well, thank you very much for inviting me to speak today on 2 important topics. I've divided them into 2 sections so that I don't get too boring. So the first section will be on iron overload and sickle cell disease. And the second section will be on vitamin D and sickle cell disease. So, for those of you who are not familiar with sickle cell disease, I know everybody here either has sickle cell disease or trait, or has a family member or is an important stakeholder in sickle cell disease. So we know that sickle cell occurs when somebody inherits an abnormal hemoglobin S. And if it occurs with a normal hemoglobin partner, it's called a trait. If it occurs with another abnormal hemoglobin partner, then it's a disease. And the abnormal hemoglobin partners can be beta thalassemia, hemoglobin C, and occasionally hemoglobin E or other abnormal hemoglobin. And this is what causes the cell, which otherwise the red cell looks biconcave and easily goes through the blood vessels, including smaller vessels without any problem because it's very flexible. The cells become stiff or sickle shape, and this will lead to aggregation in small blood vessels called vasoocclusion. And sometimes these cells, because they are abnormal, they tend to hemolyze or die early, either in the bone marrow or in circulation. So the net effect of these two processes, the sickling and aggregation of cells, as well as early hemolysis of the cells, leads to, number one, anemia, and number two, organ dysfunction. And the organ dysfunction can range from brain, where you have strokes, bone, where you have bone infarct and pain, kidney, where you have kidney infarct and kidney injury, and so on and so forth. In addition, the hemolysis also creates a secondary effect where nitric oxide is mopped out of circulation, and this leads to increased pulmonary pressures, leading to pulmonary hypertension and its complication. Overall, life expectancy, if a child is born today of sickle cell disease, we expect 9 out of 10 children to live up to age 18 and even beyond. And this is as a result of very good care that the pediatric specialty provide to sickle cell, ranging from newborn screening and identification of patients, and then appropriate follow-up to confirm the diagnosis, and then they have very good anticipatory care in pediatric. Unfortunately, once you get to the age 18, then things change. And when you look at the US overall, life expectancy is 68 years, which is 20 years less than another person who is not without sickle cell disease at age 18. And unfortunately, in California, it's even worse. Life expectancy is around 42 to 43 years, according to a survey done around 2016-17. And this is partly because of multiple factors, ranging from provider unavailability to system-based problem, including healthcare system problems, and then service-based problem, including insurability, community service, advocacy, and awareness. Fortunately, in the last few years, there have been increasing efforts to try and improve this life expectancy, at least to bring it at par to national average, and if possible, make it better. I must admit that in the past, we've focused more on identification of complication, including strokes, acute chest syndrome, acute kidney injury, bone infarct, avascular necrosis. And we've also pretty much focused on disease-modifying therapy to try and improve disease outcome. But as sickle cell patients live longer and longer, there are few problems that we need patients to be aware of. And as providers, we are beginning to try and we are beginning to focus on those areas. And some of these areas require just simple modification or early identification and treatment in order to prevent the complication from happening. One of those areas include iron overload in sickle cell disease. So the objective of my, the goals and objective of my presentation today include, my number one goal is to increase awareness among patients, providers, as well as caregivers about iron overload in sickle cell disease. And I will do this by overviewing iron homeostasis or iron metabolism, which include, iron absorption, metabolism, and elimination. And then I will discuss iron overload or iron loading in sickle cell disease. I will discuss how we evaluate iron loading, and I will touch on some of the treatments available and prevention. The focus is not on, going into details about treatment, but to create awareness so that patients, caregivers, and other providers will help the patient to ask appropriate questions to their provider and understand why the provider is doing what tests they are doing. So by way of introduction, let's talk about iron. Iron occurs in 3 basic forms, and there may be other forms, but I'll focus on these 3 forms. There is iron 2+, and iron 3+, and iron in heme protein. So overall, you know, most of the iron we take come either as 2+ or 3+ or heme. And if we take iron in 2+, the body is able to absorb it directly. But if we take iron in 3+, the body has to reduce it to 2+ in order to absorb it. And when we take iron in protein or heme protein, the body is also able to absorb it. And overall, our body stores our iron in hemoglobin, which constitutes about 80 to 90% of our total body iron storage. And small amount is stored in other iron-containing protein, which include muscle protein or myoglobin, cytochrome, which are important in energy production, and catalysis. And then the iron in circulation is stored in what we call transferrin, which is a small amount of iron. And the reason why this iron needs to be stored bound to a protein called transferrin is because iron, when left alone in circulation, is very toxic because it leads to production of free radicals like hydrogen peroxide or activated oxygen species that is toxic to organs. And if for some reason iron makes it into cells and the cells don't need the iron, it still has to be bound to another protein called ferritin. And again, within cells, iron is also toxic because it leads to production of these free radicals that will damage protein and cells. So this is a pictorial representation of where iron is stored in the body. Majority of it is in the erythrocyte, which is the red blood cells, and a small portion of it circulates in the plasma, and in the plasma is either bound to transferrin or iron transporting protein. And then the small that is stored in the muscle is stored within the enzyme that use iron as part of energy production. And the excess iron is stored in the rest of the body as ferritin, which is the tissue binding iron storage or iron storage protein. So the next slide is to show how iron is absorbed in our system. First, iron, if you take it in 3+ form, has to be reduced to 2+ in order for it to be absorbed in the intestine. And once it's absorbed in the intestine, it has to change back to 3+, and then it gets transported out of the intestine. So I'm talking about the picture to your left of the screen. And the mucosal cell is the intestinal cell, which is located in the duodenum, which is the first part of the small intestine. And it is then transported out of that through a protein called ferroportin into the bloodstream, and this is where it is bound to iron transporting protein called ferritin. And then from there, it is either transported to the liver and other organs or the bone marrow, where iron is utilized to make a heme protein, which is converted to hemoglobin, which is responsible for carrying iron around the body. And I can't emphasize enough that iron should not circulate unbound or as a single atom, because if it does that, it causes production of free radicals, which is toxic to the cells. So the picture to your right is a more detailed pictorial diagram showing how iron is transported. So if for some reason there is excess iron in the body and the amount is more than what the ferritin can store, iron becomes unbound, and it leaks from cell into circulation. And then the transferrin, which is the protein that binds iron in circulation, mops it up if the transferrin is available. If it saturates the transferrin, then the free iron is now available to circulate in the blood, and then it can get deposited in tissue to various degrees. By and large, liver is the organ that takes up most of the free iron if it is available. And then pancreas can also take some, and the heart muscle can take some. Unfortunately, the circulating iron goes into cell through iron transporting protein, which is not regulated by the body. So the more iron you have in circulation, the higher the likelihood that it enters all the tissues. So the next, we talk about iron toxicity. As I mentioned, iron becomes toxic if it is circulating in blood, or if it is available within the cells or within the tissues unbound. So if it is circulating in blood, I mentioned that the blood circulating iron is bound to a protein called transferrin. So if the transferrin is saturated, then the circulating ion becomes non-transferrin bound ion, or labile plasma ion. And then if it is in the tissue, it is bound to another tissue ion binding protein called ferritin. So I mentioned two proteins. There's a transferrin and there's a ferritin. So transferrin is a circulating ion binding protein, and ferritin is the tissue ion binding protein. So if both the ferritin and the transferrin are oversaturated, then there will be free ion that is not bound. So the free ion within cell is called labile cellular ion, and the free ion within circulation is called labile plasma ion. And it is these free ions that causes damage to either the cells, or if it is in circulation, then it gets deposited in other organs. And these organs will include liver, the spleen, the pancreas, the ovaries, the pituitary gland or endocrine gland. And then as time goes on, this causes organ dysfunction. So in sickle cell disease, what is iron loading? The iron loading in sickle cell disease is divided into two parts. We have iron loading in transfusion independent sickle cell disease. So transfusion independent sickle cell disease is anybody with sickle cell disease who doesn't require regular blood transfusion. So their hemoglobin is low, but it is not to the point where they are having symptoms from anemia, therefore they don't require regular transfusion. It is possible that they may require transfusion when they are very sick in the hospital or during surgical procedure if they lose additional blood, but otherwise, these are the kind of patients that I see who maybe once a year, once every 2 years, they fall sick and their hemoglobin goes too low, and then they get 1 or 2 units of blood transfusion, and then they are fine. In those patients, possibly they get iron overloaded if for some reason they are absorbing too much iron, or somebody placed them on iron-containing supplements. And this type of iron enters through the gut. It gets absorbed, it circulates, it oversaturates the iron transporting proteins, which is ferritin and transferrin, and then the excess free ion get deposited usually in the liver and much less commonly in the heart. And this is what will cause long-term problems in future. Generally speaking, we monitor this using ferritin level, which is the storage storage protein. And if the ferritin level hits a threshold of 800, then we have to think about possibly initiating what we call ion chelation, which is an attempt to lower the ion and remove as much as possible the free ion and prevent future organ damage. I must say that, if we don't do this early, once the organ damage happens, unfortunately, we are not able to reverse the organ damage. We only can lower the ion level to prevent further damage. That's why it is very important for us to really monitor, even if you are not transfusion dependent, we need to monitor the ferritin and make sure that we start ion chelation as soon as it hits the threshold in order to prevent organ damage. And in the past, we haven't talked about this a lot with sickle cell patients because most patients are not living long enough for us to see the consequences of ion overload and tissue damage. But as we expect our patient to live longer and longer, and this is one of the problems that we'll be facing or we are facing now. And then the next group is ion overload in transfusion-dependent sickle cell disease. And this occurs either through absorption through the gut, which is the least common. And then depending on how often you are getting the transfusion, we divide it into 3 parts. The regular transfusion, which means patients who are getting transfusion maybe every 3 months, every 4 months in order to keep their hemoglobin level below 30%, hemoglobin S level below 30%. Or patients who are getting intermittent transfusion in order to treat anemia, or patients who are on exchange blood transfusion. And these 3 categories of patients load ion or develop ion overload at different degrees. The worst of them is the patient who is getting regular blood transfusion to keep the hemoglobin S level below 30%. This is followed by somebody who is getting intermittent transfusion to treat anemia. And then, the least ion loading condition is a patient who is on regular exchange transfusion, especially if they are on what we call net neutral transfusion. Net neutral transfusion means that usually we take an X amount of blood and we put an X amount of blood in. Even though this may be much more laborious, but in terms of ion loading, this is actually the safest way to transfuse patients because we are able to balance out the ion or amount of blood. So the next is to look at how much a unit of blood, how much ion is in 1 unit of blood. So when we look at 1 unit of blood, each unit will have about 200 to 250 milligrams of ion. So it makes, so if I transfuse somebody 10 units of blood, technically I'm giving them about 2.5 grams of ion. And the body, ion is one of the few metals that the body regulates very tightly because the body knows that it needs ion for the energy system. It also needs ion to create hemoglobin to transport oxygen around the body. At the same time, free ion is very toxic to cells. So the body, unfortunately, doesn't have a very good way of eliminating ion. Most of the time we eliminate it through maybe stool or through loss of epithelia, skin cells, and sometimes in urine, but we don't have really a good way to eliminate ion. So, and then, usually we talk about somebody being ion overloaded if they get transfused at least 20 units of blood. And this can happen real quick. If you look at sickle cell disease, some patients start getting transfused as early as 6 months. So it's very easy to give somebody 10 units. So 10 units, most people, by the time they are 2 years, they would have gotten 10 units of blood. And then the next is when the ferritin level goes above 1,000. And this has a caveat because ferritin is also acute inflammatory protein. And so it can go high when you have acute infection or when you are sick, when you have crisis. Therefore, we look at what we call steady state ferritin level when you are not sick. And we follow trend rather than individual value. And then the next way to monitor iron or to measure iron overload is to measure iron concentration in the liver. And this can be done in multiple ways. The less invasive way of doing it is doing liver MRI. And we look at liver iron concentration compared to liver tissue. And if we have anything greater than 3 grams of iron per gram of liver, and some people may stretch it to 3 to 5, but overall, if you are beyond 3, we say that you have liver iron overload. And then we can measure MRI of other organs, including the heart, the pancreas, and pituitary gland, the ovaries, to determine iron loading of those organs. The most invasive of it, but the most accurate, is actually doing a liver biopsy. Nowadays, we try not to do it if we can really get the information from other ways. And this picture is just to show you iron loading depending on what kind of transfusion you do for a patient. So the red is ferritin level for of patients who were on clinical trial, who were on some type of transfusion over 1 year. So the red dots is somebody who is on exchange transfusion program. So you realize that the ferritin level for patient on exchange transfusion program is much lower, it's at the lower end of the graph, compared to the blue, which is somebody who is on manual exchange transfusion. Again, machine-based exchange transfusion is more accurate, is much easier and more easier to do net neutral exchange transfusion compared to manual. And then the highest dot is somebody who is getting simple transfusion, which means that either they get transfusion to treat anemia or get simple transfusion to decrease their hemoglobin S level to below 30%. Why is this important? So there are 3 retrospective. We don't have a good prospective data, which means randomized clinical trial, but we have retrospective data. One of them was from University of Washington, which shows that when they studied a group of patients and look at mortality of the patient who had sickle cell disease over 25-year period, at least 17% of the mortality either is directly related to iron overload or is secondary to iron overload, particularly the effect on the heart and the liver. And when we also look at patients who were transfused over a 10-year period, a third of them who were transfused over a 10-year period will have iron saturation greater than 50% consistently, which is consistent with increased labile or circulating free iron, which is also consistent with iron overload. And then the third study, and then in that study, they look at mortality and noted that compared to those who don't have iron overload, those with iron overload died at the rate, they are at risk of dying 64% times compared to 5% for those who are not iron overloaded. This, I must say, may be because those who are on transfusion have poorly controlled sickle cell disease, or it's possible that the risk of dying is actually because of iron overload. It's difficult to tease out because these 2 issues may be interrelated. So some patients get transfused because they have problems, they have uncontrolled sickle cell disease, and then they become iron overloaded, which adds to their morbidity. And then when you look at iron-related cardiomyopathy, in chronically transfused patients, the incidence is much higher compared to general population. Unfortunately, we haven't been looking, investigating this a lot. So when you look at, and for those of you who have sickle cell who are on this call, we can count the number of patients who have had MRI of their heart to determine if they have iron overload in the heart. It's not something that we do frequently partly because of technical reason. The other part is sometimes insurance gives you pushback, but it's something that should be done every now and then to determine iron loading of the heart.
I have a question.
So, yes.
My question in regards to those people that struggle with this, that are in particular regions that are different from, say, Fresno to San Francisco to LA, there's still a protocol for the transfusion and how that procedure is induced to the client or the patient, the same all across the board? Do you feel like it could be difference in how people do that practice from one place to the next? Like my brother died at 37 years old from a pulmonary embolism. Do you feel like that could have been a possibility of having an iron overload?
So ideally, when a patient is going to go onto some kind of transfusion program, you want to know what their baseline iron is, or iron loading is. Okay, and then based on their baseline iron loading, ideally they should, once you decide that the patient is going to go onto some kind of long chronic transfusion program, they should start medication to either prevent iron loading because it's inevitable, or if they already have iron overload, to try and prevent progression of their iron overload with the goal of also doing what we call net transfusion, which means that you try as much as possible to balance what you are taking out and what you are putting in, at the same time keeping an eye on their hemoglobin and their ferritin level. It's difficult for me to say if this has direct causality with iron overload. Unfortunately, most patients with sickle cell disease who have complication, and they have complication because probably their sickle cell is not controlled, and we are doing things to try and improve the control, which will include blood transfusion, and then that also put them at risk of iron overload. So it's probably a combination of factors. So
got it. Thank you.
So when we talk about tissue iron loading, the organ that approximates to total body iron is the liver. That's why those who are being monitored closely, the most common test we do is liver MRI, and we use that as a surrogate marker to total iron loading. So usually, but occasionally, we may have to do other MRI of other organs like pancreas, pituitary, heart. The correlation to total iron loading in the body is poor, but we use liver first, and then we do other organ MRI if we feel like those organs are also at risk. And I must say that no two sickle cell patients are the same. Some people have propensity to iron load in certain organs for one reason or the other compared to others. I've seen a patient who iron loaded in her pancreas and ovary and endocrine organs compared to the liver. So her liver looks relatively okay, but she had diabetes, she had premature ovarian failure, all from iron loading in those organs. And this is because free iron go wherever it wants to go, okay? There's no way to control where the iron decides to go wherever it wants to go. So it may happen that those organs have what we call iron transporters, which allows iron into those cells preferentially compared to that of the liver. So it's important to keep an eye on other organs in addition to the liver. So some patients will have a protocol where every 2 years, and if you are going to do liver MRI, if you can add, if you want to do the whole thing where you do liver, heart, and pancreas, you can you do that. Or occasionally they have a protocol where they do liver MRI every 2 years and heart MRI every 2 years, and then MRI of other organs depending on what else is going on. So this graph is just to demonstrate that when you look at, if you pay attention to the portion which says LVEF, left ventricular ejection fraction, and then the R cardiac ion, you will see that the higher the cardiac ion goes, which is the lowest of the curve, the lower the ejection fraction goes. So when you look at the ejection fraction, as soon as the ion level in the heart goes above, so ion level in the heart is measured based on conduction in the heart. So the higher the, like if your ion level is high, your conduction millisecond decreases. Okay, does it make sense? So the more ion in the heart, the easier it allows conduction. So when you look at heart, we have a cutoff of 20 milliseconds. If your conduction is less than 20 milliseconds, it means the ion level in the heart is high. So the higher the conduction in the heart, the higher the ion level, and the lower the ejection fraction. Similarly, if you have ion accumulation in the liver, the higher the ion accumulation in the liver, the worse the liver function, the higher the likelihood of developing cirrhosis and sometimes liver failure. And then similar thing applies to other endocrine organs, including pancreas, the thyroid, the parathyroid, the ovaries, the testes, and so on and so forth. So what are the clinical signs and symptoms of ion overload? Depend on the organ involved. So in the liver, the first and foremost sign is increase in liver function tests, particularly AST and ALT, but AST more than ALT. And then as time goes on, the person may progress to cirrhosis from ion overload and then liver failure. For heart, first is decreased contraction or congestive heart failure, and then arrhythmias, because when you have deposit of ion, it interferes with electrical conduction in the heart and cause arrhythmia. And then you may develop a fulminant cardiomyopathy. And then for pancreas and other endocrine organ diabetes, thyroid hypo or hyperthyroidism, depending on, the situation, and then hypoadrenalism or hypopituitarism. And then for reproductive organs, hypogonadism, which means low testicular or low testosterone production, which may lead to decreased libido, impotence, and in females, unfortunately, irregular menstrual cycles, premature ovarian failure, and so forth. The other thing that we are beginning to see is arthropathy, which means joint and bone problems. For instance, increased ion will lead to deposition within the joint and cause premature arthritis and arthropathy. And then it may also lead to bone marrow failure. So it is not unusual for patients who have ion overload to develop worsening anemia because the ion is toxic to bone marrow producing cells. So we know that in sickle cell, the bone marrow compensates by working extra hard. So if you have something which is toxic to the bone marrow cell, that compensatory mechanism is taken away, and therefore they may have anemia that cannot be explained and is out of proportion to their overall sickle cell state.
Dr. Bukari, I have a question.
Yes.
What about the kidneys? You didn't mention kidneys, or I didn't see it in that list with the rest of them. And my son had kidney failure, so I'm trying to see how does that play into the, why didn't you mention, or how come kidneys wasn't in the list?
So kidneys, fortunately, do not accumulate a lot of iron. But what happens in kidney is what we call vaso-occlusive crisis, like the VOC, the micro infarct or small infarct in the kidney is what causes the kidneys to deteriorate. So the kidneys suffer more from vaso-occlusion compared to other organs.
Okay, great. Thank you. Thank you.
Right.
Perfect. Good.
So in terms of screening, go ahead.
Oh, no, I just wanted to say hi for a second.
Hi.
Man. You again.
In terms of screening, how do we screen for iron overload? We mentioned that, we can look at the number of RBC transfused. So if you've been transfused up to 10 units or more, your risk of iron overload is high. So that's the first screening tool right there. So when I take over patient, I ask them, how often do you get transfused per year? If you are transfused maybe once or twice a year, by the time you are 10 years old, you are at risk of iron overload. I must say that fortunately, some patients who have hyperhemolysis will have intravascular hemolysis as well. And when you have intravascular hemolysis, you also tend to lose some iron in urine, okay? So that can act as a protective mechanism. And if you are a female and you are also menstrual, that also acts as a protective mechanism because you are also losing some iron during menstrual period. So overall, most of my female patients, when I look at my patient profile, those who are not transfusion dependent and they are females, chances that they will have iron overload is a little lower than males because they still have, at least during the time that they are menstrual, they still continue to lose some iron during the menses, so they are protected in a way. As soon as the menses stops, that is when now they are not losing any iron. So anything that their body absorb or you give them, they keep it. So it's important. The reason why, I believe that patient empowerment is the most powerful tool. I had a young lady who, when she goes to the hospital, she will not get out of the hospital unless she gets transfused. Even if her hemoglobin is good and she's not hypoxic, there is really no strong indication for transfusion. She just feels better if her hemoglobin is high. And the reason she develops some kind of correlation, when she's feeling good, her hemoglobin is 8. So when she goes to the hospital, she says, look, get my hemoglobin to 8 because that's when I feel the best. As soon as I sat her down and we discussed, iron overload, what transfusing her means, how much iron she gets with each transfusion, and the danger of having iron overload and its effect on heart, lung, liver, and pancreas. Right now, when she goes to the hospital, if you want to transfuse her, she's gonna ask you so many questions. Why do I need transfusion? Did you talk to my doctors before you are ordering transfusion? If you don't talk to my doctor, I'm not taking any transfusion. So I believe that empowering patients on their health is actually the most important aspect of patient care.
Dr. Bukari,
Yes.
Mr. French has his hand up.
Mr. French, go ahead.
Yeah, so I just found out that my brother was taken off the pheresis because of iron overload. And I'm trying to understand, what is the process in that situation? I know that we do the XJ and all that, or however many other medications there are for it at this point. But what would be something he could do to make sure that he can still keep up with making sure he gets his regular treatments while at the same time keeping the iron level down, if that makes sense?
So like I mentioned earlier, any sickle cell patient who is put on regular transfusion program will have to, we have to first of all determine the indication for transfusion, okay? And we need to, it should be ongoing evaluation of indication for transfusion. And in our next talk, I will talk about transfusion and development of alloantibodies. Unfortunately, the more transfused you are, the more difficult it is to get blood for you because your body tends to develop alloantibodies. So every now and then your doctors need to step back and ask themselves, what is the indication for transfusion? Do you still need ongoing transfusion? Is there anything we could do to help out? So in your brother's situation, those will be my consideration. And then if iron overload is in the mess, then I will have to decide whether doing what we call net exchange transfusion, which means that we try as much as possible to take the same amount out as we are giving him. And then we need to optimize iron chelation, by doing whatever we can to reduce as much iron as possible. occasionally, and maybe we might be getting towards that, and where one of the medication called voxelotor, which can help with the hemoglobin level. So for some patients who are on transfusion because of severe anemia, if we can give them voxelotor to raise their hemoglobin level, then they may not need transfusion. So I don't know the details of the decision process, but those are the things that I will be asking myself. Does your brother need ongoing exchange transfusion? Has he had antibodies to the point where it is difficult to get him his unit of blood? And is there anything else we can do in that situation? Because the more transfused he is, the more antibody he develops. Unfortunately, the more difficult it's going to be to get blood when he needs it. So moving on, number of RBC, and then we have 3 monthly ferritin check, and then we can do annual, what we call liver iron concentration evaluation using MRI, and then annual or biannual cardiac MRI. So once we screen, then we can make a diagnosis. We make a diagnosis, we use ferritin level, in combination, we may combine it with iron saturation. A few words about ferritin. Ferritin is an acute phase reaction protein. It's unreliable. And therefore, when we are using it, we have to make sure that we use what we call steady state, or state when you are not in crisis or you are not sick. And then iron saturation also varies day to day, so it's not the most reliable. By far, the most reliable way of monitoring total body iron that we use is the liver MRI. And then occasionally we also do heart MRI to determine if you have cardiac iron overload. So the lab evaluation or the lab values that we use, we have a cutoff for ferritin. For low, normal ferritin should be up to 300. If you have between 300 to 800, I will put you at risk of iron overload. And these are the patients that I monitor very closely. And if you are ferritin level greater than 800 and less than 1,700, the risk is higher. So again, those patients need to be monitored much more closer and initiated on chelation if needed. And these are the patients that sometimes we order MRI of the liver to try and get a better assessment of your iron loading. And if you have high ferritin greater than 800 and you have some evidence of iron overload in the liver, then definitely you should go on iron chelation. And then there's a very high risk, which is ferritin greater than 2,500. And those patients, by and large, will need some kind of iron chelation to reduce the ferritin down. And then we have other tests like cardiac MRI, pancreas MRI, and we have various cutoffs to determine normal, moderate risk, severe risk, very severe risk. Oh. Next is when do we initiate chelation? So we screen you, we did additional testing, and by and large, like I mentioned, most people who have had at least 20 to 25 units of PAC RBC transfusion more than likely will need chelation. But again, this may need additional testing to confirm that. And then patients who whose ferritin is persistently between 1,000 and 1,500 either will need additional evaluation or might benefit from chelation. And if your liver iron concentration is definitely greater than 5 grams per gram of dry weight liver, yes. Between 3 and 5, maybe additional monitoring and repeat testing, or some people will say, let's start the chelation early in order to prevent further, because once the storage occurs and there's tissue damage, you're not going to be able to reverse it. What are the principles of iron loading? And this is one of the things that I always say, that the patient needs to understand what the goals are. Overall, the goal is to decrease the plasma and cytosolic like the free ion. The free ions include the non-transferring bound ion, which is, and then labile plasma ion. So non-transferring bound ion, labile plasma ion. And we have a surrogate markers. So The goal would be to reduce the ferritin below 1,000 if possible. Some people might argue that let's go below 800 in order to be on the safer side. And then the liver iron concentration, we want to keep it below 7, and if possible, below 5. And then cardiac conduction, we want to keep it above 20. Remember, I said that if you have iron loading in the heart is going to be more conductive. Therefore, we want to keep it above 20. What are the principles? To maintain reactive forms of iron within normal limit and minimize side effect of chelation, improve compliance, and increase patient-provider collaboration. I believe if a patient knows why they are taking the medication and what the goals of the medication is, they are more likely to comply. So every time you come to my clinic, I make sure that I show you the numbers. I show you, Miss S, we started iron chelation because your iron level is 3,500 for the last 6 months. This is the trend we are. We need to, number one, increase compliance if we want to get to this point, or increase the dose, or do both. Generally speaking, once a patient knows the numbers they have today and the numbers they are hoping to achieve, they are much more compliant. And every now and then I have patients asking me, so what's my ferritin level? What's the goal? And they want, just like everybody else, everybody wants to achieve a goal, right? But if I don't know the goal and the patient doesn't know the goal, then it's difficult to have a discussion. So I will encourage all sickle cell patients, sickle cell caregivers to always ask your doctor. So, we are taking medication to lower my ferritin. What's the goal? Okay, if I get to this goal, can I get to reduce the dose, or can I take a break? Of course, if there are certain levels, let's say if your ferritin level goes to below 500, most patients will be taken off chelation and be monitored closely, and then restarted if needed. And what medication do we use? We have 3 medications that are approved for lowering for iron overload. The oldest of them is deferoxamine, which is DFO. Unfortunately, it works really well. The downside is that it's subcutaneous or IV. And apart from young children, most adults, they are like, you know what, no way, I'm not doing that. So even though it works, you have to put the IV on for at least 8 hours, 8 to 24 hours if possible. And it's one of the quickest to reduce the free iron. And there are some complications that are associated with this treatment, including injection site reaction, allergic reaction to medication. It's also the medication that is associated with high likelihood of hearing loss, eye problems, and infection with Yersinia bacteria. So anybody who is on this needs a close monitoring of their hearing. They need at least once a year eye evaluation to make sure that they are not having any problem. The next one, I'll go to the extreme right, is deferoxamine, which comes in, or deferoxyros, which comes in 2 forms, the S-Jade and the Jade-Nu. Similar medication, one of them has better bioavailability and is much more tolerable by adults compared to children. Most common side effect, nausea, vomiting, diarrhea, skin rash, and this medication, we actually need to pay close attention to the kidney function. And then the middle of the table is diferipron, which also comes as a tablet or syrup. Generally in the US, this is not very commonly used. We usually use it for patients who have cardiac iron overload. And it's one of the medications that we need to pay attention to your blood count at least once every 3 months at minimum. When you start this medication monthly, you need to have monthly blood count because it can lead to very low blood count, including neutrophil count, and put you at risk of infection. And the 3 medications, they work pretty good. They have slightly different mechanism of action or how they work, and different side effect profile. Generally speaking, in the US, we use deferoxyros in either S-jade or jade-nu form, and we kind of manipulate the dose in order to attain our goal of ion chelation.
Dr. Bukari,
Yes,
Ali has his hand raised.
go ahead.
You're on mute.
Hi, Dr. Bukari. I had a question about these drugs. I know that like the free iron, unlike other ions, is hard to like excrete out from the body. Do these drugs help with metabolizing and excretion, or does it do like one or the other?
So all of them bind free ion to various degree, and then the body excretes the drug with the ion, either in the feces or urine or combination. But the best of them is actually diferoxamine. It has the highest binding capacity for free ion. So for instance, patients who have ion overload and cardiac toxicity, acute cardiac toxicity, they are actually better off with diferoxamine because it lowers the free ion level quickly and restore your heart function. You know, but all of them bind free ion, and then once they are bound, the body eliminates both the drug and the ion. Does it make sense?
Yeah, thank you.
And, you know, we have occasionally, you know, one medication may not be enough to attain the goal, especially if you have cardiac ion overload. Sometimes we may have to use combination. Usually, the combination that have been studied in small study is diferoxamine plus diferoxirose, or diferoxamine plus diferoprom, or diferoprom plus diferoxirose, or S-jade with diferoprom. So sometimes we use this combination to try and optimize the ion chelation. And then we have few other supportive measures that we do. I'm sure some of the patients who are on this call are on vitamin C supplementation. The way it works is that vitamin C helps to mobilize the ion and allows the medication to mop it out. So the way to look at it is you take something to mobilize the ion from the tissue, and then the chelation agent will eliminate the ion. And then occasionally patients who have ion overload with its effect on the heart, we may use calcium channel blocker. Remember, I mentioned that when you have free ion, the ion enters the cell through channels, and ion is +2, right? Calcium is also +2. So calcium channel may be a way ion enters the heart. So some patients, we may put them on calcium channel blocker to block the channel and prevent free ion from entering the heart. So that's the principle behind that. But these are like supportive measures. They haven't been proven in clinical trial to be very effective, but we do it if there is really nothing, you know, to be done. After you optimize all the chelation agents, you are using combination, and you still have some cardiac toxicity, then you consider calcium channel. Or if you optimize, you know, the chelation agent, and then you are still having high ferritin or high liver ion concentration, then you add vitamin C to see if you can mobilize and chelate. What are the monitoring for ion chelation? You know, I mentioned audiometry, which means hearing assessment. So patients who are on chelation should have at least once a year hearing assessment. It may be at the clinic, and if there is a problem, then you get referred to ENTF for formal assessment. And then again, eye examination. And this, you know, this is not the examination by optometrists. It has to be that by ophthalmologists. And they have to be aware that you are on ion chelation, or you are a sickle cell patient who is coming for evaluation. When I send patient, I write clearly sickle cell patient on evaluation, and then sickle cell patient on ion chelation. And I tell the patient, when you go to the doctor, tell them you are here because you have sickle cell, and they need to look at the fundus. They need to do dilation and look, because it's one of those that the earlier you detect it and correct it, the better. other blood count, kidney function, liver function. So for pediatric, you need to monitor their growth because all the ion chelation can impair growth, and then endocrine function like thyroid function, maybe A1C monitoring, adrenal insufficiency monitoring using cortisol, and so on and so forth. So how do we prevent ion overload? That's the bottom line. Restriction of transfusion to only appropriate indication. So patient needs to be aware that getting transfusion may not necessarily be in their interest if it is not indicated. And patient needs to be their own advocates because it is easy. Remember, you're gonna go to adult hospital, especially for adult patient, where anytime somebody presents with hemoglobin of 8, they transfuse you. So as soon as they see the number, they transfuse you. You have to be on your guard and ask the doctors, why am I getting transfused? This is my baseline, If I'm not having any problem, don't give me transfusion unless you talk to my doctors. It is very easy. This is one of the most common things that happen to a lot of patients. You go to the hospital, they see hemoglobin of 6.7 and they order transfusion. Meanwhile, you are fine. You've been 6.7 probably all your life or 7 all your life. So I tell the patient, if you are 2 grams below your baseline, then I look at your reticulocyte count. If the reticulocyte count is high enough, I know it's gonna get better. If reticulocyte count is low and you are 2 below your baseline and you are symptomatic, then you get transfusion. Occasionally, even if you are not symptomatic and you are not reticking appropriately, I know that you're gonna get worse, so I give you transfusion. But otherwise, I'm very, very strict on when to transfuse. And then automated exchange transfusion is probably the way to go compared to manual, because then you can do net neutral transfusion. And then you optimize your disease modifying therapy. And fortunately, now we have a medication that can help increase the hemoglobin, voxelotor. And so for patient who is symptomatic, who has symptomatic anemia requiring frequent transfusion, maybe that's a medication that can be used to reduce that. And then avoid ion supplementation unless it's absolutely necessary. And this, sometimes I tell patients, female patients, yes, we tell you don't take iron, but of course, because of menstrual bleeding and some people may have prolonged menstrual bleeding, for those patients, if you have to be put on iron, you have to make sure that you have a complete iron profile and they document that your iron level is low. Otherwise, no. So I'll end here for ion overload, and I'll open the floor for questions.
Ali, your hand is still up. Did you have anything else?
Yeah, I was just gonna ask if there are any other drugs that are being like made or at clinical trials to reduce free iron in the blood.
So there's one drug that had preliminary evaluation. It didn't pan out well. This is one of the areas that I believe we need a lot more work. Unfortunately, as sickle cell providers, we haven't paid a lot more attention to this area compared to thalassemia providers. Thalassemia providers have pushed more for new medication, research into even the combinations that I spoke about. We don't know which combination works the best. We need additional evaluation and we need new treatment in this area. And I believe that as our patients live longer and longer, and we are hoping we can restore life expectancy for sickle cell patients to as close to normal people as possible.
Dr. Bukari. We have a question here by Andy. Can diet be a source of iron that needs to be managed?
Diet, right? So yes, so fortunately, compared to thalassemia patient, it looks like sickle cell, at least from preliminary evaluation or investigation, it doesn't look like dietary iron plays a significant role in iron overload for sickle cell patient. This is a little different from patients who have thalassemia. You know, patients who have thalassemia have a lot more iron absorbing capacity compared to sickle cell patients. Theoretically, it could contribute, but practically speaking, it looks like in sickle cell patient, it is transfusion, which is the source of their iron loading. Does it make sense?
Thank you.
Okay, we have another question.
What is the effect of iron overload with people that are not living with sickle cell?
Good question. So there are people who have congenital iron overloading condition. We call it hemochromatosis. Okay, and there are certain genetic defects that put you at risk of hemochromatosis. And the net result of iron overload on the liver, the heart, the pancreas, the ovary is the same, whether you are iron overloaded from sickle cell or thalassemia or any other hemoglobin abnormality, or you have genetic defect that causes excessive absorption of food iron. So those people with hemochromatosis, they have hyperabsorption. Even if they don't take iron-containing food, their body is so efficient in absorbing iron from food that they tend to develop iron overload. So for those patients, there are a few things that we advise in addition. You know, if your liver is at risk of damage from iron overload, try to avoid alcohol intake, avoid anything that will make, you know, the organ damage worse. And similarly, in sickle cell patients, we also advise if you are at risk of iron overload, you don't want to do something that will increase the risk of organ damage. But the net result is the same, whether from sickle cell, thalassemia, or another genetic abnormality. Good question.
Thank you.
So maybe we can go to, I'll stop sharing this and share the next one, which is going to be a very short presentation.
At the moment, we'll attach the AEP evaluations. So if you can please take a moment to also look at that in the chat. Actually, Dr. Bukari, what we could do is we could take a 10-minute break.
Yes, and then I can get the next slide ready.
Sounds good. Let's see, it's 12:18. Does 12:25 sound good? Okay, we'll come back at 12:25. Thanks, Talina. I will attach the AEP, the link to the AEP evaluations.
Martin, do you have the new slide on? It should read sickle cell and bone health.
Yes, yes.
Okay, good.
Thank you. And if someone can let me know that the link works and All right, well, we will see everyone at 12:25.
Hey, Dr. Bukari, before we start, I just had another question. You were talking about between thalassemia and sickle cell, that in thalassemia, people living with thalassemia have more, they're more, you said they absorb more iron.
Yes.
Is that because the pathophysiology of the disease, or are they more transfusion dependent than people living with sickle cell?
So it's combination. Remember, thalassemia people have a lot more expanded bone marrow space. And, thalassemia is more ineffective erythropoiesis. While sickle cell is, abnormal erythropoietin and RBC. So when you look at bone marrow space of sickle cell compared to thalassemia, the thalassemia bone marrow space is much more widened. And so their requirement for iron to maintain certain level of hemoglobin is much higher. While sickle cell, the problem, yes, they have hemolysis, it's not as hyperhemolysis as thalassemia. So again, when you look at, complication of hemolysis like gallstones and all that is much more prominent in thalassemia compared to sickle cell.
Because one is quantitative and one is qualitative.
Qualitative, yes.
Okay.
Yes, so that's the reason. So, when you take age and condition, level of hemoglobin and age, compare thalassemia to sickle cell disease, thalassemia patients are more likely to be highly iron loaded because of the contribution from GI absorption, and increased GI absorption compared to sickle cell patient. And that, I suspect, is probably the reason why iron overload hasn't been paid attention to in sickle cell patient compared to thalassemia patient.
And how about people living with both beta thal sickle cell?
So beta thal sickle cell, for sickle cell complication, comparing SS to S beta thal, maybe S beta thal, maybe. Remember when we talk about complication, VOCs and strokes and all that may not have that much. And then again, the need for transfusion may not be that much. But again, phenotype and genotype sometimes doesn't match. So if you take sickle cell beta thal, 3 different people, same genotype, but the phenotype may be slightly different. Yeah.
Dr. Bukari, I have a question about when you were talking about when the question was asked, what if you don't have sickle cell and you can have iron overload? Do doctors look for that, or is that detected early, or how do you know that your body is, if you don't have sickle cell or any of that, how do you know that?
Good question. So, a lot of that, I get referral because another family member got diagnosed with iron overload. So generally speaking, maybe you did blood work for another reason, and it shows that your liver enzyme is elevated, and then they do iron saturation, and the iron saturation is more than 60%, or they do your ferritin, and your ferritin is like more than 300 for males and more than 200 for female. Then that requires you to be sent to the hematologist, and then we will do what we call hemochromatosis evaluation. It's the genetic test. And then when the test result comes back, if you are positive, then we encourage you to have other family members get checked. So that's the most common reason why we get patients. So sometimes a patient comes to me and say, my sister got diagnosed with hemochromatosis and my doctor wants me to come and check.
Thank you.
All right. Yeah. So hopefully the next topic is going to be a relatively short topic. So sickle cell and bone health. Again, now that our sickle cell patients are living longer, we are beginning to pay more attention to, I will say, I call it optimization. Optimization means, we are doing things to kind of help patients live better and patients develop much less likelihood of complications. So bone health is one of the areas of optimization. Okay, so it's really not direct sickle cell problem, but it's something that if we manage properly will kind of decrease the chances of bone complication. Okay, so moving on, the goals of presentation: to create awareness of vitamin D, bone health, and sickle cell disease. I will discuss sickle cell disease sickle cell bone diseases. I will discuss the role of vitamin D in sickle cell bone diseases. I'll talk about metabolism of vitamin D. I'll talk about some supplementation, and I'll open the discussion. So sickle cell bone disease can be divided into two general categories. There is acute sickle cell bone disease, which we are all familiar with, include acute vaso-occlusive crisis or pain. And then we have osteonecrosis or bone infarcts. And then we have bone infections, which include osteomyelitis, which means bone infection, and septic arthritis, which is joint infection. And non-sickle cell related pathology. Remember, sickle cell patient can have other problems, bone problems, like fractures, dislocation, and yada, yada, yada. And then sickle cell chronic bone disease. And this is where complications of acute bone disease, like septic arthritis and osteomyelitis, will lead to chronic arthritis or osteoarthritis, and it can lead to avascular necrosis. Avascular necrosis means dead bone, particularly in the head of femur or hip, but it can occur in other joints like the elbow, the shoulder, and this will lead to decreased joint mobility and pain or combination. And then we have osteopenia and osteoporosis. Osteopenia is low bone density. And then osteoporosis is weak bone. And then compression fractures. So low bone density and weak bone will lead to fracture of the bone, particularly backbone. And then chronic pain. There are some patients who have none of this. They just have pain that cannot be explained by anything. And last but not the least, which I didn't put here, is falls. Especially as our sickle cell patients grow older and older, some patients will just have multiple falls without any good explanation. And majority of those patients will have some kind of vitamin osteoporosis, osteopenia, compression fracture, or vitamin D deficiency. And bone disease is much common in sickle cell SS compared to sickle cell S beta thal compared to other sickle cell variants. The only caveat to this is patients who have alpha thalassemia in addition to sickle cell. For those patients, unfortunately, it does look like bone disease is actually much more common. So let's say if you have SS plus alpha thalassemia, the bone disease will be much more common. And we know that bone disease starts as early as infancy, 6 months. Most patients will have dactylitis or hand-foot pain or hand-foot disease, and this occurs throughout life. So when you take sickle cell patient born at birth, at least half of them will develop bone pain involving small joints of the hand by the time they are 6 months. And it's actually one of the most common presentation. And I mentioned that avascular necrosis is a little more common, or is more common when you have alpha thalassemia trait in addition to sickle cell. And it is this bone abnormality or bone disease that actually cause impairment of quality of life. Believe it or not, when you look overall, the older you get, your quality of life decreases significantly as a sickle cell patient, mainly from bone disease. It's not from stroke, it's not from heart attack, it's not from kidney function, but bone disease and pain. Okay. Therefore, early diagnosis and prevention actually is helpful if we have to improve overall quality of life. And we know we've been doing much better with, utilizing disease modifying medication to prevent renal dysfunction, to prevent stroke, but this is one of the areas that we need to improve. Pathophysiology, bone disease is actually from ischemia or low oxygen to the bone, and inflammation and infection of the bone. That is for acute bone disease. For chronic bone disease, it is from repeated infection or repeated ischemia. And sometimes Ali asked about expanded bone marrow space. So if the bone is made up of bone marrow space and cortical bone, which is the bone itself. So each bone has bone marrow space and the bone itself. If you have expanded bone marrow space because of chronic anemia and sickle cell, the bone tends to be much weaker. And unfortunately, other factors may modify this, including obesity, smoking, alcohol use, lack of exposure to sunlight, and vitamin D deficiency. So vitamin D deficiency may not be the principal culprit of sickle cell bone disease, but it may add on top of sickle cell bone disease, and then things may get worse. So if we can remove all the other factors, including obesity, smoking, alcohol use, increased exercise, and prevent vitamin D deficiency, we may actually prevent sickle cell bone disease or reduce the incidence of sickle cell bone disease and improve quality of life.
Dr. Bukari.
Yes.
I have a question. So for the most part, bone disease, well, I know we're talking about sickle cell disease, but can people with the trait have any of, what you've discussed thus far? Can we have bone disorders, or can any of this, do people with trait get any of this?
Mostly, by and large, no, because they don't have ischemia, they don't have infarct, they don't have infections directly related to sickle cell disease like osteomyelitis or septic arthritis. But most people with sickle cell trait are people of color. And we will see later that people of color are at risk of vitamin D deficiency. And if you are sedentary, you have obesity, and you smoke, you may have bone disease that is separate from sickle cell disease.
Right.
So for sickle cell disease, it's like for somebody who is sedentary, a person of color, who smokes, who is obese, who has vitamin D deficiency, that is a double whammy.
Okay.
So you have sickle cell bone disease and you have other non-sickle cell bone disease that is adding on top of your bone disease. Does it make sense?
Yes, got it. Great. Thank you. Yes.
So that is why I said this topic is not directly related to sickle cell disease, but it's something that we need to do to optimize the bone health. So risk factors for sickle cell bone disease in general, sickle cell bone disease mirrors sickle cell disease control. So if your sickle cell is controlled, your bone disease is likely going to be controlled. And then it also depends on genotype, and then your hemoglobin F level. It depends on co-inherited alpha thalassemia, and then body mass index, smoking, alcohol, and vitamin D deficiency, as well as use of certain medication. And we have osteopenia, which is osteopenia is when your bone is not that strong, and osteoporosis is weak bone. And this occurs as a result of decreased calcium buildup in the bone from multiple reasons, which will include vitamin D deficiency, because you need vitamin D to absorb calcium and to deposit calcium in bone. And this puts you at risk of fractures.
Dr. Bukari, we have a question on the chat. Is sickle cell / thalassemia an exception? if it's an exception.
Sickle cell and alpha thalassemia. What's the question?
Thalassemia?
So if you have alpha thalassemia, even if it's a trait, and you have sickle cell on top. So remember, sickle cell involves beta gene, okay? If you have just sickle cell without alpha thalassemia, your risk of bone disease is high, but not as high as you have sickle cell and alpha thalassemia trait. And unfortunately, this is very common in Africa, actually, because the alpha thalassemia trait is actually very common. And then you have sickle cell on top of it. So you have patients whose sickle cell, overall, sickle cell is not too bad. They don't have so many crises, they don't have pain frequently. Their hemoglobin is not too bad. Overall, their sickle cell is pretty controlled, but they have much worse bone disease compared to what we would have expected. For instance, you have a patient who doesn't have crisis, maybe one crisis a year, is living normal life, and then they have bad hip pain or hip necrosis, avascular necrosis of the hip. When you do their thalassemia gene evaluation, they may have thalassemia trait, which is making it worse, or it's making the bone disease worse.
Okay, and can I just clarify something?
Yes.
I should have put in there that I have sickle cell traits and thalassemia B, and I do have sickle cell, all the same sickle cell traits that are issues that everyone else has.
Yes, so beta thalassemia, and so you have S beta thal, okay? So S beta thal, yes, you have all the symptoms that sickle cell patients have, but not as severe degree as SS, okay? But
Correct.
obviously, like I said, there's a genotype and there's phenotype. Or in a layman's term, there is what we know and what we expect. Sometimes the genotype and the phenotype doesn't match. Have I seen people with sickle cell beta thal have worse complication than sickle cell SS? Yes. But that is not the norm. The norm is that if you have S beta thal, yes, you have all the sickle cell problem, but it shouldn't be as bad as SS. But again, each patient is different. So how common is weak bone and fragile bone in sickle cell disease? When they did a cross-sectional study of sickle cell 87 patients in Saudi Arabia, and they look at osteoporosis or weak and fragile bone, when they look at the male patient, 6 out of 10 patients will have fragile bone. And when they look at the female patient, 6 out of 10 will have fragile bone. As to how much sickle cell is contributing to the fragile bone and how much all the other factors, including vitamin D deficiency, contributing to fragile bone, it's not clear. And then another study looked at 73 patients with sickle cell disease age 15 to 80, and they look at incidence of what we call abnormal bone density. And believe it or not, as many as 7 out of 10 patients will have abnormal bone density, which ranges from osteopenia, which is weak bone, osteoporosis, which is fragile bone. And it was recognized that patients who have osteoporosis, they also have other complications of sickle cell. So it may be that the sickle cell and other factors are working together to cause the osteoporosis. So how do we manage osteoporosis and osteopenia, or weak and fragile bone in sickle cell disease? Early identification and effective management to prevent compression fracture, because once the fracture happens, then it actually affects the quality of life a great deal. And then we need to do disease modifying therapy of sickle cell to try and reduce the effect of sickle cell on bone. And then we need to optimize bone health by supplementing vitamin D if it is low, and or preventing vitamin D deficiency and optimizing bone health. And then there's physical therapy, and then there's bisphosphonate, which is bone strengthening medication that can be given to improve the strength of bone, and we need to monitor patient closely. So this brings us to vitamin D deficiency. So what is the prevalence? Overall, vitamin D deficiency is very common, and it's estimated between 50 to 90% of sickle cell patients will have vitamin D deficiency. And overall, being Black puts you at risk, or being a person of color puts you at risk also of vitamin D deficiency. So, you know, unfortunately, vitamin D deficiency is common in people of color. Sickle cell is common in people of color. Okay, so if you are a person of color and you have sickle cell and you have vitamin D deficiency, your bone health is going to be the worst. So the best thing to do is to eliminate other causes of bone disease in sickle cell patients, so that we only have to deal with sickle cell as a cause of bone health deterioration. So why is vitamin D common in people of color? There are two ways we get vitamin D. One way is through vitamin D containing food called egocalciferol, which is to your right. And then the other way is vitamin D from sunlight using cholesterol from skin. Unfortunately, if you are a person of color, your skin is not as efficient in producing vitamin D from cholesterol compared to somebody who is not a person of color. West off is when you are living in Western Hemisphere, or Midwest. If you are a sickle cell patient and you live in Midwest, or sometime in the East Coast, you know, maybe in Michigan, for instance, half of the year you don't have very good sunlight, or even if there is good sunlight, you are not outdoor, you are always wearing protective clothing. So your chances of producing vitamin D from your skin is very low. Fortunately, in California, we have a lot of sun and the weather is not too cold, but even then we always are wearing protective clothes. So how much exposed skin we have is also in question. So we are really left with only one source, which is from food. Okay, and then the egocalciferol is broken down by liver, or is modified by liver to produce vitamin D or calcidiol. And then your kidney also modifies it to produce 1,2,5 vitamin D or calcitriol. So there's egocalciferol or cholecalciferol. And then there's calcidiol and there's calcitriol. And it is the calcitriol which is responsible for increasing absorption of calcium and increased calcium deposition into the bone to form strong bone. It also reduces the ability of your kidney to excrete calcium. So what are ways people develop vitamin D deficiency? Through poor intake, poor absorption, especially patients who have had gastric bypass, and then decreased skin synthesis, and patients with cirrhosis, renal failure, and other organ dysfunction, because apart from your skin making it or you taking vitamin D in food, your liver and the kidney will need to modify it into functional forms. What are the risk group for vitamin D deficiency? Patients taking certain medications, patients who are hospitalized or institutionalized, patients of color, patients with limited or people with limited light exposure, and patients who have malabsorption syndrome. And what is optimal level of vitamin D? For us to say that your vitamin D is okay, there are two different definitions. But by and large, if your vitamin D level is between 20 and 40, we say that's optimal. In some laboratory, they use 30 as a cutoff. If it's more than 30, that's optimal. And then we have three categories. There is vitamin D insufficiency, where your level is between 12 and 20. So it's insufficient, it's not deficient. And then there is vitamin D deficiency if it's less than 12. And then there's vitamin D toxicity if it is more than 100, okay? All my sickle cell patients, I will prefer you to be vitamin D sufficient, okay? Which means that your level should be more than 30, at least to give you an optimal bone health. How do we measure the vitamin D level? Across board, we can measure 3 different vitamin Ds. We have the normal vitamin D, which is what is done in most laboratory, but you can also measure vitamin D2 or D3. And how often do you measure it? For most other patients or for general population, as and when the physician deem it fit. For sickle cell patient, we like to measure it at least once a year, okay? And if you measure it, you want to optimize it because we want to optimize your bone health to reduce the impact of sickle cell bone disease. If I find it the level to be suboptimal or insufficient, what can I do about it? There are different ways of supplementing. You know, for normal adults, we have a daily supplementation, which is 600 to 800 international units. Fortunately, there are preparations that has 400 units plus calcium. So if you have a preparation that has 400 international units plus calcium, you need 2 of them every day, so that it will give you optimal vitamin D supplement, and it will also give you calcium supplement, okay? And so usually sometimes it comes 500 milligram of calcium or 250 milligram of calcium and 400 units of vitamin D, or 250 milligram of calcium and 200 units of vitamin D, or 500 milligram of calcium and 400 units of vitamin D. Regardless, the daily recommended allowance should be between 600 to 800. And if you can take it with 1,000 milligram of calcium, that is optimal, or 1,200 of calcium. If your level is low though, then we need to supplement you to bring you to normal, and then give you recommended daily allowance to keep it normal. So we have to differentiate 2 ways of supplementing. One is your level is low, so we need to bring it up to speed. And then we need to give you daily supplement to prevent it from going low and optimize your bone health. So when you go to your providers, you always need to make sure that they are checking your vitamin D at least once a year. And if it is low, they need to have supplementation to bring it to normal, and then supplementation to keep it normal, to optimize your bone health. Okay, I call it supportive care. And there are other preparations that are available in the market. There's calcidiol, and this we use it in patients with liver disease. Remember, I mentioned when you take vitamin D in food, it has to go to the liver, metabolize it into active drug, and then it goes to the kidney, metabolize further into 1,2,5 vitamin D, which is what is promoting calcium absorption. So if you have a liver disease, the preparation we recommend should be a little different, because if you use the normal preparation, it's not going to work. Your liver is not going to be able to activate it, okay? And then, so these are where the nuances come in. And this is where your doctor needs to, really look at your condition and determine which supplement is optimal for you. If you have kidney disease, then it means we have to give you active vitamin D. If we give you the regular vitamin D, which requires the kidney to metabolize into active form, it's not going to work. So that is where we recommend calcitriol. As a matter of fact, most doctors now, they just give you calcitriol because that's the most active form, and that's the form that we know is going to work, regardless of your liver, your kidney, doesn't matter. Okay. What are the benefits? Optimizing vitamin D level, either by treating vitamin D insufficiency or deficiency and supplementing it to keep it normal, will help optimize your bone strength, prevent falls, prevent osteopenia, osteoporosis, and compression fracture. And it also has some beneficial effect on immune function. And for sickle cell patients, we always recommend at least to have once a year vitamin D check, supplement to bring it to normal, and then supplement daily to optimize your bone health. So that's what I summarize. I would like to end here. I think this is a short presentation. It is not directly sickle cell, but it's something that I feel, will help in the overall management of sickle cell.
Thank you so much, Dr. Bukari. Let us open for questions. Feel free to also send them in the chat or the DM. Let's take a moment for questions. Yes, go ahead, Ali.
Sorry, did I raise my hand up? I didn't have a question.
Oh, my apologies. Yeah, I saw the.
So the message I really want to leave with everybody who either takes care of a sickle cell patient or family member or whoever is sickle cell patient, I believe is one of the diseases that we really need collaboration, patient and provider collaboration. It's the only way to optimize care. If we are working as a team, the patient, the provider, the healthcare system, the insurance, everybody is working as a team. And, we need to reduce a lot of conflict. Let's work as a team and provide the best care possible.
There you go. Zelose, you want to speak?
Yes, this is Zelose. I'm a patient with sickle cell, SS. Thank you, Dr. Bukari, for both your presentations. They were very, very educational. I learned a lot about iron overload and the bone disease. Very useful, thank you. My question was on the necrosis of the bones. I did suffer from necrosis in my shoulder.
Mm-hmm.
And I did have a fracture there that I was walking around with for months due to the sickle cell. Eventually, when they caught it, they fixed me up with a bone decompression surgery.
Mm-hmm.
This was 10 years ago. And since then, I had very limited mobility in my arm after the problem and after the treatment, but it's been 10 years and I've since gained back my range of motion. There's still a little pain there, but it's nothing that I cannot live with. I can live with it. It's not very bothersome. Recently, I've been having much more pain in the same area. And I went to see the doctor. He's a good doctor. And he said that as long as I'm not having severe pain, he won't do anything. He will just let me be. Doctor, do you have any recommendations for things we can be doing to prevent severe pain, to prevent worsening? Because I think in the end we will worsen, like cutting back on that time frame where our conditions get worse and worse. I noticed I got better with my range of motion after starting yoga. And now I lift some weights, like 5 pounds and 3 pounds. Does that help with the bone health? Just wondering.
Yes, so, overall, sickle cell bone disease is one of those diseases that we need to have what we call, anticipatory evaluation. So let's say there are certain areas that we need to, each time a patient comes, you need to ask, is there pain there? Is there difficulty in range of motion? Yada, yada, yada. And if if we identify any symptoms, we need to fully evaluate. And when they are fully evaluated, we need to fully take care of it, either surgically or non-surgically. And then, you know, if you develop new symptoms in that same area, you know, probably, I don't know who you saw was an orthopedic surgeon or not, but it's probably better to see an orthopedic surgeon and get repeat evaluation, including either X-rays or MRI if needed. And occasionally, if nothing needs to be done, then you need to be considered for physical therapy. And so each joint has what we call muscle that actually stabilizes the joint. So sometimes increasing the strength in that muscle will help you a great deal as far as pain is concerned and range of motion is concerned. So if you haven't seen a physical therapist recently, I think it's something that you need to do to get a more thorough evaluation and maybe what we call joint strengthening exercise. And this, even when you look at footballers, when they have knee problem, the quadricep muscle is the muscle that strengthens the knee. So sometimes we recommend quadricep muscle strengthening. And once that is stable and strengthened, you know, your pain overall improves. And then we need to look at what about your calcium, your vitamin D, you know, do you have osteoporosis? If you have osteoporosis, will you benefit from osteoporosis management with bisphosphonate? And remember, I'm not sure how old you are, but if you have sickle cell, you are at risk of bone disease. If you are a female and postmenopausal, you are at risk of bone disease. So you're one of those people that, you know, may need a DEXA scan early, you know, and I think based on these two conditions, if you are postmenopausal and if your doctor writes all the indication, the insurance should be able to allow you to do a DEXA scan or bone density scan. And if you are osteoporotic, then we need a bone strengthening medication to strengthen your bone, and then conditioning or weight-bearing exercise, which you are doing already, which also helps specific muscle. But I will recommend to see a specialist so that they can teach you what weight-bearing to a specific muscle that will help. In your case, I suspect what we call you know, there are specific muscles in the shoulder joint that helps strengthen the shoulder joint. You know, so if it's not just any exercise, you need to see somebody to teach you what exercise strengthen what muscle.
Thank you very much. That was very helpful.
Yes.
Okay. If there are no further questions, I want to thank you, Dr. Bukari, for this awesome and informal and informational presentation. Now, before I give any updates, I did put up the wrong link, which I thank you for letting me know for the evaluation. So if you can just take a moment to do the AEP evaluation form. And let's see.
Dr. Bukari, we have another question.
Yes.
Yeah.
Okay. If someone has a knee replacement, how does that affect the marrow in the bone below that replacement?
So, you know, usually the older we get, the long bones, especially in the leg and arm, are no longer hematopoietic. What that means is that their blood cell forming capacity goes down. They get replaced with fat. So in older people, it is the backbone, the rib bone, and the breastbone which take over bone cell production or blood cell production. That's why even for older people, when we are doing bone marrow biopsy, we tend to go to the hip bone. So it shouldn't really affect your ability to produce blood cells a whole lot, you know, so long as you are much older compared to if we are talking about somebody who is younger, maybe below teenage years.
Okay, thank you very much.
Okay. So let us start off with, let me just share my screen. So if you haven't yet, for those, definitely check out our SCAA website, where you can find out our latest updates, events, programs that are coming up, such as our advocacy and empowerment, where if you were to scroll down, you can find out that, so next month we have Shirley Powell, who's a client, and the topic is on relationships. Also check us out on our Instagram, where you'll find out also the latest things that are popping up, events. If you check out our Facebook page, we will also post up the links, the Zoom links for our future AEP sessions, our events that are coming up, as well as if you want to look at previous AEP sessions, you can go to our SCASF on YouTube, where here you can just see all of our previous AEP sessions, events that we've done, such as here we have Victor Reynolds, we have Segundo de Mayo, and all of these. So check us out and follow us, and also please fill out the AEP evaluations. The info that is collected from these surveys also is important to show our financial supporters and to maintain the program along with your continued support and as well as attendance. And let me stop sharing here. And as far as events, yes, I can paste this in the chat.
I just want to thank Dr. Bukari for a fantastic presentation, all of that very valuable information. We couldn't have gotten it better. It was very well served and very clear. So Dr. Bukari, I just want to thank you, and just know that we'll have you back again to talk about a different subject, sir. You have a great day, and thank you so much for your time.
And thank you very much. And I'm happy to, present, I believe, in small topics rather than a big topic. So
yes, I think we got a lot of questions answered and everything. So it was very informative.
Thank you very much.
All right, everyone. Well, thank you for being here. Dr. Bukari, once again, awesome presentation. Everyone have a great weekend. And Nadina, Edward, I'll see you soon.